Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself since 2005, and the co-founder, chief medical officer, and executive vice president of the nonprofit CLL Society. Dr. Graff, can you introduce yourself, please?
Yes, thank you for having me. So my name is Dr. Tara Graff, and I am here in Des Moines, Iowa. I am a medical hematologist oncologist specializing in non-Hodgkin's lymphoma, especially CLL. I run our clinical trials program here, and I'm looking forward to talking to you guys tonight about CLL and measurable residual disease.
Well, Dr. Graff, the first thing I want to point out is that you're this non-Hodgkin's lymphoma specialist, but CLL has the privilege of being both a leukemia and lymphoma at the same time. And we're going to kind of focus more on the leukemia side of it right now. And we're going to talk about MRD, which is called either minimal or measurable residual disease. So tell us what that is. What are we talking about here?
So the way I like to explain it to my patients when talking about MRD is that, after you complete therapy, or even along your treatment course, patients will ask, well, is my disease gone? And, traditionally we've relied on labs and especially with CLL, from the blood standpoint of CLL, and in some cases imaging. But, is that enough? Is that sensitive or specific enough? Well, enter MRD, measurable residual disease or minimal residual disease. And now I look at it like picking up cancer at the microscopic level or at the cellular level. We always talk about crumbs of cancer being left behind. Well, what MRD does is it allows us to pick up those crumbs before they ever show up in the blood or ever show up on a scan. So it's like having a bird's eye view into the future, to be able to help you plan and design your treatment course and continuation of treatment with your patients.
So MRD has been around for a while, and there's different ways to do it, some older ways and some newer ways. Can you explain those? And then maybe we can talk about the different sensitivities and what that means and how clinically important that could be.
So for a long time, we relied on something called flow cytometry. And not to date myself, but I remember, getting my master's degree in immunology and doing flow, back in 2001, right? Flow was new back then. And what flow does in a nutshell is you are using stains, fluorescent tags, if you will, to put on cells. And then you're using light scattering to have them go on a certain part of a graph, or we'll say a chart, to pick up abnormal cells and separate them out from normal cells. Whereas next-gen sequencing, or NGS, is almost like breaking down your proteins or your DNA and RNA into little pieces and making your own personalized little barcode and running it out, we call a gel, or doing electrophoresis, a whole different modernized way for detecting your individual clones, if you will, or your particles of disease. So they're really not comparable. I mean, they get us to maybe a similar answer, if you will, but in a very different way and at a different level.
So are there advantages to both tests, or one test over the other? Or explain, like, flow seems to me what I see most of the time. When I read a paper and it talks about MRD, that's usually referring to flow. So is there advantages to flow and advantages to the NGS, next generation sequencing testing?
I mean, I think the advantage to flow is that we're just more familiar with it. But it's not as sensitive as, or I mean, when you talk about level of detection, it goes to 10 to the minus fourth, whereas next gen sequencing,
That's 1 in 10,000 cells.
right, which is versus 1 in a million with next gen sequencing. So you can pick up those crumbs at a smaller level, if you will, with the NGS. Now, with anything, the older is usually more widely used because we're familiar with it. It's cheaper, right? Cost is an issue. You can turn it around a little bit faster. Your own pathology lab can typically do it rather than having to send out, which a lot of labs have to do, or a lot of pathology labs have to do. And so I think there's just different nuances to it.
So when we're talking 1 in 10,000 or 1 in a million, are we talking 1 in 10,000 what? Lymphocytes, blood cells? Yeah. So any cells with nuclear material, or like would when we're looking at the blood? Help me understand that.
So you're talking about the specific cells causing the leukemia.
Okay. All right.
Yes, sorry, I should have clarified that.
Okay. So, and now I know this test can be done in the blood and in the bone marrow. Could you talk a little about the difference and if there's correlation between these two and when you would need one versus the other?
So with CLL, we're fortunate that we can do it in the blood or the bone marrow. For other diseases, that's not necessarily the case. Not everybody with CLL has disease in the bone marrow. So in that case, you wouldn't be, using your sample on the bone marrow. And getting a cellular sample in your lab with a peripheral blood draw is certainly a lot easier than putting somebody through a bone marrow biopsy. For certain clinical trials, they like to see, whether the disease is detectable or undetectable in both spaces, both the peripheral blood and the bone marrow. They do correlate fairly similar, not perfectly. It's not, completely equal in all circumstances. But when we're looking at, especially in the clinical trial setting, we usually like to see it both in the peripheral blood and in the bone marrow. In everyday practice, it's used more in the peripheral blood.
Well, it's certainly easier from a patient's perspective to get the test
Yes,
done in the peripheral blood.
Mhm.
And I would be thinking, and we'll get to the implications of when to use it, but if I had undetectable MRD in the blood, I might want to know what's going on in the marrow. But if I have detectable MRD in the blood, odds are it's also detectable in the marrow. So why go through an unpleasant, at best, procedure?
Right.
So talk to me a little bit about what it means when it's detectable versus undetectable. Obviously, less disease is better, but if I'm undetectable, does that mean I could be cured of my CLL, that it's all gone?
So no. So with undetectable MRD, this is obviously a great thing, right? This means that those crumbs they're not there, which essentially means I would use the word remission. I would not use the word cure because we know that CLL is not curable, at least not yet, right? We know that it's a disease that has it follows a fairly, in some cases, chronic course, but we know that it can go in and out of remission. So I don't want to use the cure because that, undetectable can unfortunately in some cases become detectable again. So no, to clear that up, it does not mean that an undetectable MRD result means you're cured and we're done. Okay. But undetectable is a victory, right? That means that we have cleared the body of any detectable crumbs. We've cleared the body of the disease at that moment in time. And for some people, that may be a very, very long remission, right? But for others, depending on time points that it's tested, we do know that undetectable can, once again become detectable, in the future. And that looks different for all different cases and different patients.
Well, that lets me kind of look at this trend, and you mentioned that too. I know that MRD can be used to see if the disease has been, to our best of knowledge, gone below measurable levels, but it can also be used to follow trends and look for clinical or molecular relapse. Let's talk about the relapse. So I've completed therapy, I've stopped therapy, I'm undetectable. I see you again for a 6-month follow-up, and now you can detect it. Is there a role for MRD in terms of following trends and predicting what's going to happen? Is that trend important?
Yeah, I think that trend is important because, we all have patients that, and physicians that practice differently, right? You want to keep patients on close active surveillance. And a patient might say, well, I just want to see you once a year. And you're like, well, no, that's not a good idea. I don't recommend that. And, here's why. And so what that allows you to do, let's be honest, it's personalized medicine, right? This is what we're trying to do. We're trying to create a personalized plan for every patient. So say I see a patient back with that 6-month follow-up and they now have detectable MRD. They've got, say we're using next-gen sequencing, we have some cells that pick up, all right? Now, that doesn't mean I'm going to start them back on treatment. That doesn't mean I'm going to do anything differently, but it's a conversation that I just had this conversation with a patient last week. I said, we're picking up your cells. You're feeling great. You have absolutely no symptoms of relapse, but I don't want to quite let you go to 6 months again. I want to see you back in 3 months. I want to repeat this. If everything is stable, then we can decide on pushing you out. But at this point in time, I know that we need to keep a closer eye on you. And that's how I use it. It doesn't mean I'm going to change anything. I would not let it, if a patient's asymptomatic, I would not let it, make me want to start therapy and start giving them treatment again. But it's something that I think is a really useful tool we have now for really working with our patients in a personalized manner.
Well, let me ask you, there are these two tests with significantly different sensitivities. So I know for a fact you can be MRD negative on one test and MRD positive on the other. So help a patient understand what that means and how that might be significant to them in managing their disease.
So we talked about this 1 in 10,000 with flow versus this 1 in, a million, basically with, we talked about the difference in sensitivity and specificity. We'll leave it at that. And so when I have a patient that has undetectable MRD at 10 to the minus fourth, right? So 1 in 10,000, I'm happy, but I'm like, well, is that a real, durability, right? You always want the most negative number in this case is good. So 10 to the minus fourth isn't bad, but if you can be 10 to the minus sixth and be negative, that means you are in a deeper response, which means, if you're negative at 10 to the minus sixth, you're in a remission. And I would feel comfortable saying you're in a remission. At 10 to the minus fourth, it's good. And I'm not saying you're not, it's just that it doesn't have that depth or that durability it does that the next gen sequencing provides. So I prefer, when at all possible, relying on next gen sequencing, because I know if that's negative, then those crumbs really aren't there.
And we know that in CLL, there are some treatments where getting to MRD is not critical with the BTK inhibitors and whatnot, and patients do really well. But with a lot of the limited duration therapies, it is important. Talk to me about something that you were hinting at here, because there seems to be increasing data that the deeper the remission, the deeper that MRD status, the longer the patient goes into time to next treatment. But not only that, progression-free survival and maybe even overall survival is better. So tell me, I know this is very early and maybe not yet in the clinic, but there's certainly emerging data on this. What's your thoughts on this and what can you share?
So when you look at some of the preliminary data that's been done, whether disease is undetectable at 10, we'll just say 10 to the minus fourth, 10 to the minus fifth, 10 to the minus sixth. When you see those lines, if you can envision a graph with different colors, when you see those lines, we'll say for progression-free survival, meaning your time where your disease is not there, there's no signs of progression. You will see that patients with a undetectable MRD at 10 to the minus sixth will have an exceedingly longer PFS than patients with
PFS is progression-free survival.
Progression-free survival. Yep. So should have said that again. Yes, progression-free survival. So for some of our fixed duration therapies, with different combinations of drugs that we're using now in CLL, that really means something. Especially when you're talking to the patient about, patient will says, okay, it's gone now. Well, how do I know, like, what's my percentage that it's going to come back? Well, if you can say to them at the end of treatment that, well, you're undetectable at 10 to the minus sixth, you can safely, we can't predict everything, but safely say, the odds of this recurring, it's never a 0% chance, but, you do have the, likelihood of this staying in a remission for a much longer period of time, as best as we can predict. And we don't again, as we have more time points and more time to see this data, then we'll be able to say, PFS at 5 years is this, PFS at 7 years. With any study, people are living longer, so we're going to have to continue to follow up on the data.
In one subtle point that I wanted to point out that applied to me is after I had a particular therapy, CAR T therapy, I was undetectable measurable residual disease to 10 to the minus 6 using clonoSEQ, next generation sequencing. But I wasn't in a complete remission because one of my nodes was still slightly enlarged. 3 years later, it's still the exact same size, 16 millimeters, it's slightly enlarged. And what the data seems to be saying is UMRD, undetectable measurable residual disease, is probably even more important than complete remission, which used to be the gold standard. Would you agree that things are shifting in that direction?
100%. We've seen the data, those of us that are in the CLL world, that you could have undetectable. So for instance, a person with undetectable disease, or undetectable MRD, that is in what we call a partial remission, right? So still on their scan has a node here or there. That person that is negative or undetectable MRD with a PR is going to,
Partial remission, yeah.
is going to do better overall than somebody who is MRD positive with a CR, right? But historically, we've in the CLL space, we have always looked for the CR, right? Complete response on a scan. That's been our victory. But what we're learning when we're looking at MRD and imaging together, that it is actually more important to have that undetectable MRD than to have a CR. So again, to kind of recap, an undetectable MRD with a PR, that person, for on all accounts that we know right now, is likely going to have a longer progression-free survival than a person who has positive MRD and a complete response on imaging. And so what I think we're moving into, if you don't mind me elaborating, is we tend, I think, to over image our patients, and not just in CLL, but in other lymphoma as well. And people and patients, rightfully so, they've lived for that next scan, right, to make sure that everything is going to be gone. But what we're allowing ourselves to do now is rely on a newer and a better method for detecting cells. So we're not constantly setting up patients for CT scans and PET scans, but we're actually able to use this newer technique, if we're referring to NGS or next gen sequencing, to monitor them, with just regular blood in the lab when they come for their regular draws, rather than having to go through, drinking contrast and things like that. So, I think it's a really exciting time. I think, the newer ways for monitoring patients, knowing if we can take patients off of therapy, I think CLL is really becoming a personalized medicine example, at its latest and greatest. So
let's get really practical here. You're talking about some of the places it's used, and I'm going to try to nail you down on that. Where shouldn't it be used? It's not useful at time of diagnosis, right? Or beginning therapy, because we already know that you have detectable disease.
So what I would say to people, and I've seen this error a lot. What I would say is that when a patient is diagnosed with CLL, if they have a large enough disease burden, again, when you're talking about these tests, you have to have measurable disease. I mean, to start with, you have to get an ID. You have to define the sequences that are unique to the patient, right? So I always try and get an ID just to have a baseline on the CLL patient, okay? And then if I'm just have them on active surveillance and we've never done any therapy, there's really no role to do additional testing. I mean, I'm not doing anything. There's no intervention to measure. We're just keeping a close eye on them. Now, at some point, if I see them showing signs of progression, their white blood cell count is going from, say, 25,000 to 80,000, and their red blood cell count is dropping, or their platelets are dropping, and we're seeing other signs of progression, and I know I'm going to start initiating therapy, that's when I would, obtain a new baseline to see what has changed. But really, if you're just, observing the patient in a non-treatment situation, there really is no use in ordering that test. You want it to help guide you with something, not just do it to do it. So that's one example where I've seen it misused. Unfortunately, a little bit more, because whenever you have a new test, people sometimes want to order it and they're not exactly sure. Like, you need to know what to do with the answer that you're getting. So
I'm going to just underline one of the points and ask you to explain it a little bit more. Is my understanding with the next generation sequencing is, let's say you've come in, you've gone through treatment, you're doing great, your absolute lymphocyte count is really low, and you say, I want to do next generation sequencing, it might not be is easy to do if you haven't gotten a baseline measurement of those genetic sequencing. So you're saying that maybe you want to get that done up front when the disease is easy to grab in the blood.
Right. Because what happens is if, say, they show signs of progression, but it's just a minimal amount, you may not have enough there to actually measure and track. And, now if they happen to have a bone marrow that was done at initial diagnosis, you can pull those samples, but I'll be honest with you, depending on how long that bone marrow has been archived in the pathology lab, that specimen might not be sufficient enough to even get what you need. And so then you run the risk of, not enough sample, or, it's just ruined and you can't get your ID. So what I've learned from my own experiences with not being able to obtain, a fresh ID, is that if I can capture them when their disease burden is the highest at diagnosis, then I have it. I have what I need. I may never need it, but I have what I need in case I need to use it in the future.
So it sounds like you're using it in two settings. One is to follow the trend of the disease and see how it's progressing, but also to see how your treatments are working and when you might be able to stop treatment and when you might be concerned about treatment coming back. So it's helping you manage the disease. Am I capturing all of that?
Yeah, I think that's accurate because, with CLL, we have so many different therapies that we can use on patients. And, some are continuous and some are fixed duration. They have a finite stop period. But when you're telling a patient, oh, you're going to be done within a year, they might say, well, how do I know my disease is gone in a year? And that's a very good point. And so I always tell patients I'm going to use this fixed duration regimen, but I sort of tread lightly that, depending on what your MRD shows at the end of 12 months, we may or may not continue you on, an oral medicine to keep your disease at bay longer. And we're seeing a lot of that as some of our fixed duration studies are being, reevaluated and new arms are being added to see that, yes, this might be fixed duration for a majority of people, but not all people. And so that's where MRD really comes into play. The other situation that once in a while we're in, with our drugs, the BTK inhibitors like acalabrutinib and zanubrutinib, and these are continuous therapies. So you don't necessarily need to be doing MRD testing, but you will have a patient that might say, you know what, I just want a break. I want to know what my disease is doing. I just need a break. I'm tired of being on medication every day. And even though I'm not a big fan of stopping the continuous therapy, that's a situation in which I would use MRD testing, because if they don't have any detectable cells or clones, at least I can say, okay, we've done a really good job with this. So let's go ahead and give you a break for 3 months and, see where you're at when you come back. Again, I'm not a fan of stopping, but there are cases in which, the patient is going to dictate what happens next. So.
And we did get some encouraging data out of IWCLL and patients who'd been on BTK inhibitors, mostly ibrutinib, for 6 years plus, who did much better than I thought they would, just stopping therapy, So it does suggest that, that the role of MRD may be underutilized, in those cases. Though generally for someone, if your absolute lymphocyte count is high, there's no point in doing MRD testing because
No.
yeah. So I think we've covered just about everything, but let me just be clear. I've got this. So I always like to say MRD does not mean that you're cured, but you have to pass MRD on the way to a cure.
You do.
There are some potentially curative therapies with transplants, bone marrow transplant, allogeneic stem cell, hematopoietic stem cell transplants, very rarely used, but they can help. There are some people with the right markers with FCR that look like they may be cured. And there's a handful of people, CAR T, that may be cured. There's a couple, there's other exceptions here and there. So I don't see it as a curative therapy. So it's not to look for a cure, but it's kind of look to how to manage the disease. Is that?
Yes, I think it is a perfect way to know how to individually manage the disease, because we have to think of every CLL patient as an individual. We are truly in that. I think it's treating CLL is so different now than it was 15 years ago. Where you really like, I had 3 patients just this week. They had to sit down and discuss treatment options, and it's wonderful to begin to talk about treatment options, right? You can be on this medication, but it's continuous. You can be on this medication. We can discuss this clinical trial. To be able to sit down and actually give them multiple, multiple options is wonderful. And so I think, again, it's a tool to use to manage your patients individually. And like you said, you have to pass it on the way to cure. I hope that someday soon we are at that point, but that is how we're going to be able to monitor getting to that point. And so I think it is a very useful, necessary tool that I think we need to educate more on, so that we are, using this to help our patients and to guide our patient treatment.
And just again, to put an exclamation point behind something, if you go from undetectable to detectable, that does not necessarily mean, oh my God, I need treatment tomorrow.
No, the interesting thing is what we're seeing from different studies, that you could turn from undetectable to detectable, but you may not show any signs of clinical progression, meaning with symptoms or on imaging or in labs for years. So it doesn't mean that. It's almost, again, like I always use the example, having a bird's eye view. You're like, okay, I got some crumbs in there, but my life's not changing. I feel great. I'm traveling, I'm golfing, I'm doing my thing. Then you continue doing your thing. It's just that you're not going to get rid of me for a year. I mean, that's all that it really means.
Yeah, and I can talk from a personal, having gone from undetectable with next-gen sequencing to 1 in a million cells. It was a full 3 years before there was any clinical indication that it was time to consider treatment. But it was nice to know, to plan, to see what the landscape was, to be talking to my physicians about what I should be doing next. It's nice to have that lead coming in. So I found that incredibly helpful in terms of, and my doctor too, in terms of how to manage and what the dynamics of my disease were. And oh, it's accelerating now. It's doubling quicker. Let's get ahead of it. So it's incredibly helpful.
The one thing I was going to say about that is it gets patients involved in their own care. And I love that. I always say it's a two-way street. It's a relationship. And you show a patient a scan of their stomach or something, they're like, what is that? But you show them that graph with their number downtrending, they can really get behind that, right? They're part of it. They understand that, oh yeah, that means things are decreasing. So I think, just to what you were saying, it really allows them to really understand. It's tangible. They can understand it at a much easier level.
And we talk with patients about being involved. Our motto at CLL Society, smart patients get smart care. And we supply charts and graphs for them to monitor their absolute lymphocyte count. But I love when I get from clonoSEQ my MRD, and I can follow it along, and I can follow what it is and whether it's from the blood or the bone marrow, and I can make those comparisons. So any final thoughts or anything you want to give to the CLL and SLL community about monitoring MRD using next-gen sequencing, using flow?
I would just say that I think it's a very useful tool. I think it's something that if you haven't had done, I think you should talk to your physician about, and just, hey, do you do this here? Can I have this done? Is this something we should be checking with my disease? And again, everybody's very different, and it might be a case where you don't need that. But I think, again, knowledge is power, right? Smart patients, we're talking about this. And I think the more that, the more we educate our patients and their caregivers, the better questions and the more you're going to get out of your treatment plan and your time with your physician. So I would encourage you to ask questions. Just ask your physician, if we're not doing this, why aren't we doing this? Can we do this? And so that'd be my one piece of advice. I think it's fantastic for patients, and it really is a good way to connect you, with your oncologist.
Dr. Graff, I learned a lot from this conversation. Thank you so much, and thank you for making it accessible to our patients. Thank you very much for all you're doing.
Thank you for having me.